but he's gonna be up here.
I'm just gonna shoot it and see what happens. Because it won't be the last time I teach this, so it won't make a difference. How do I make this go away? I want to make this disappear. I did Saturday too. Alright. So what we left off with was, so we're talking about like, how does Narcan work, basically? Huh? Yeah, so you can talk freely, I'm gonna edit it. That's all okay. How does Narcan work? So we're talking about like, mu receptor. Can you hit that light, bro?
Yes, sir.
Or is it displaying okay? Kind of look at the camera and tell me. Is that all right? I'm gonna turn the light back on and see which one look better. Let me see the board, okay?
Yeah, this is better.
That's better? Okay. Does it get my good side? I don't have a good side. You can say it. You can say it. It's okay.
I mean, I thought it was a good side both ways.
I'm just joking. All right, so we're talking about mu receptor antagonism. Now we're talking about our buddy's naltrexone that you can now get from CVS and Publix and stuff like that. All right, and basically, like the question was, if you are overdosed on an opiate, and you imagine, let's just say this is heroin, and someone is like hypothermic, they're respiratorily depressed, they're blue, they're about to die because they're overdosed on heroin. How is it that we can give Narcan and it reverse it, all right? So the way to think about it in my mind is the person's overdose, and you know, we're using this kind of as a very simple representation of the lock and key model for receptor activity. But remember, you got like throughout your body and in your brain, you got these mu receptors, right? And understanding that there's a concept called a K value. And this is from pharmacology class. The K value is a value they use to describe the affinity for the receptor, right? So the lower the number, the higher the affinity. Higher number, the lower the affinity for the receptor, okay? So the trick is that naloxone has a higher affinity for the receptor than, say, heroin would. So it's kind of like when the 49ers play the Cowboys, right? Right? It's like the Cowboys think they're doing good by blocking this receptor, and they're getting all this hype, and they're talking about Dak's the MVP, right? And they look good against everybody who's trash, right? Like the Eagles, who are pretenders, because they just got destroyed by the Cowboys. Cowboys suck. And then the bullies on the block come. Naloxone, also known as the San Francisco 49ers. They come along, kaboom, blow these off the receptor, all right? Because they don't belong there. It's a pretender, all right? Because it has a higher affinity for the Super Bowl, okay? So if you notice, this mu receptor is shaped like a bowl, and my drawing is very super, all right? So that will help you remember that forever, Eagles fan, that so that if naloxone is in the presence of a mu receptor agonist like heroin or whatever it is, since it has a higher affinity for the receptor, it's going to knock it off of the receptor and reversing the activity of this. So we want to turn these mu receptors off in that situation because, well, you're overdosing. And like clockwork. So I always watch some of that lecture. What's up?
Sorry, I reached out to that patient from this afternoon that has 2 appointments on
Yes.
there, one being a cat.
Yes.
he always sees Raquel, so
Yeah.
I called him. His voicemail like never comes up. It just
Yeah.
continues ringing.
Yeah.
Called his other contact, left a voicemail.
Okay.
So there's an appointment with Raquel available Wednesday. He can take that. So I'm gonna keep trying to see if I can
It's
contact him to get
It's fine. When he
clarification.
gets here, I'll just do my regular session with him
Yeah,
and reschedule, because I'm not planning on doing cap with him.
yeah, and
Yeah.
that's why I'm trying to, contact him, let him know, like, hey, don't
Yeah.
take anything, like,
Yeah. Yeah, I just do like a regular session with
Okay.
him, and we'll just reschedule that.
alright,
Yeah.
sorry about that.
No, it's cool. No worries. Okay. All right. So does that make sense? Pretty straightforward. All right. So remember that the purpose of this is to serve people clinically, not just to pass the test. But I feel like the more fundamental understanding you have of why we do what we do, the better clinician you are, because you're not just looking stuff up based on the situation and just doing what you just read and not understanding why you did what you just read. Okay. So here's kind of the quick run through of what we covered so far as a quick summary. Number one, when it comes to opiate intoxication and all of the drugs like we talked about, the intoxication and the withdrawal tend to be opposites, right? The body strives to be in homeostasis. So whenever you have addiction processes, you're thinking about up and down regulation of receptors, okay? That's why over time, when people use any substance, they grow tolerance, because you start down regulating receptors, you have less of those receptors, so it takes more of the chemical to cause the same effect over time. So unfortunately, I'll give you an example. This may help you remember. Okay, this was a very sad day for me, but I had a patient that I was taking care of at a residential level of care. She was 16 years old. And when she came to the hospital, we were treating her for depression and like borderline traits and self-harm, but also opiate addiction, because she was stealing granny's opiates. And she worked with us in the hospital. We had her there for probably 6-7 months in the hospital, because this is residential level, before the insurance really clamped down on that. And we had been working with her, and mind that she had not taken opiates for 6 months. When she left the hospital, the insurance just one day just sent us that we're not paying for her to have care anymore. Our argument was she did not have a support system, that she was still depressed, and she still had, self-harm behaviors. But they said, but she's not suicidal. She doesn't need to be in the hospital. She went home. She was dead in 3 days, unfortunately. Because day one, when she got home from the hospital, she got in a car accident. She went to the ER. They saw her history. They wouldn't prescribe opiates for her. Okay. 2 days later, she goes to Granny's house, back to old habits, thinking, because she's 16, that she could take what she used to take. And she overdosed and died. And that was a very sad day for me. But it really highlights this phenomenon. So why did she, from a receptor point of view, why did she lose her life? Can y'all explain that? Like, why did she die? She was taking the same amount that she used to take.
So over time, the amount of receptors when she was addicted was less, and then whenever she got out and took all the medication that she used to take, it actually overstimulated the little amount of receptors that she had.
Okay, so she wouldn't have had you were very, very close. You misspoke. I know that you understand the concept. You slightly misspoke, but you're right. So, in the context, this is her default. Let's imagine that these 2, 4, 6 receptors are the default. You get this how many mu receptors that you have in a normal state. And then you start taking opiates every day. And your body's like, wait a minute, that's not normal. We need to adjust because we can't function under this context. I'm trying to hit homeostasis. So what you do is you down-regulate your receptors. I didn't mean to do that, so we'll do X. So now, for me to function, I've reduced my receptor count by 50%. So that if you keep taking the same amount of opiate, it's not gonna give you a high, or a very mild high can still function because the brain's striving for homeostasis. Then she went to the hospital, couldn't get opiates, and it's been 6 months. Okay, so now in this situation, the brain's like, all right, we back to normal, everything's Gucci. So now my brain can't function normally without me having the right amount of receptors. And I'm going to draw them crudely. So now the brain's repopulating these mu receptors, right? She didn't know that though. So when she comes out and she takes the same amount of opiates, now all the receptors are occupied, and then you get all the CNS depression that comes with that she wasn't expecting. So she stops breathing, unfortunately. So hopefully that very sad story can kind of help consolidate in your mind why people have issues with tolerance and are at risk for overdose. So I got 7 minutes before my patient. So this is a good segue into kind of the mindset behind how do we use, and I won't be able to finish this right now, and I can't spell it, buprenorphine. Good old Sabato, right? And if we just have buprenorphine, what's that called? What's the trade name, do you know? Subutex. Okay, so these are your two market chemicals we use in opiate dependence. Suboxone is the standard. Typically, you don't use Subutex unless they're pregnant. Okay, so that can be used in pregnancy. So you should not be prescribing average people not pregnant Subutex because they can more likely abuse it. Okay, so the concept behind this, and this is what they're going to make you learn when you get this on your license, is that instead of having a full agonist like the drugs that they're abusing, right? So I guess I can get it this way. So the reason that people continue to abuse opiates is because how sucky the withdrawal is. In our last lecture, I told you you're a hot mess when you're withdrawn. And you have all the opposite symptoms of the intoxication. So the primary one that makes people keep using is pain. So they have an enhanced level of pain, and you cannot quench that pain. So people go use again, okay? So when people are in that addiction cycle, they'll use, they'll avoid withdrawal, they'll usually get some type of euphoria, and they can go a certain period of time, usually a day, maybe 2, sometimes 3, and then they'll be in withdrawal, so they gotta use again, okay? Because they can't function in that much pain. So we need to break the cycle. And there's a couple ways you can break the cycle. One, well, you can just go through the withdrawal. Most people won't choose that because it's so uncomfortable, but withdrawal from opiates is not life-threatening. It sucks, but not life-threatening, okay? So that's one way. Most people cannot sustain that because not only is it a physiological addiction, it's a psychological addiction, okay? Second way we can break the cycle is by using a medical intervention to introduce a mu agonist, that would be methadone. So we're replacing something illegal and abusive with something prescribed and controlled, right? It still can be abused. They're still addicted to it, but the controlled fashion in which they receive the medicine, such as going to the clinic once a day to get your medicine, avoids all of the other risks associated with the medicine, such as, selling drugs to get money, or prostituting, or sharing needles. It reduces the consequences of it, but you're still addicted. Buprenorphine is a little different. Buprenorphine, which is the third way to break the cycle, is actually a partial agonist at the mu receptor. So if you remember the concept of partial agonism, partial agonists work kind of like a thermostat. So in conditions where there's a relative deficiency or low level of a certain chemical, it's going to work as an agonist. So in this situation, so if you're replacing an opiate and there's none there, it's going to act as an agonist. But it's not going to be a full agonist. It's going to have partial activity on the receptor, not the full activity of the receptor, which is perfect because you, at the right dose, what you get is an avoidance of the withdrawal symptoms without precipitating the euphoria and all the good stuff that comes along with it. So you just feel normal at the appropriate dose because it's a partial agonist. Okay. Now, remember, partial agonists also can work as an antagonist. So they block the receptor 2 in situations of a high amount of this chemical opiates. So they got opiates in your system and you give Suboxone, it's going to work more like an antagonist, kind of like naloxone and naltrexone. But here's the beauty of the medicine. So remember, this is a combination medicine. And the concept you got to understand about these two is bioavailability. If my pen wants to write bioavailability. And I'm not the best speller, don't judge me. I used to be a great speller. I won a spelling bee when I was a kid, right? And then after I got my title, when I retired, I was like, I'm not spelling ever again. It was too traumatic for me. So now I just spell terribly on purpose, all right? I'll tell you that story later. All right, so bioavailability is a concept to understand about buprenorphine and naloxone. So Suboxone or Subutex is oral medication. All right. So buprenorphine has a very high bioavailability when given orally. Okay, that's what we want. We give the medicine, high bioavailability. Also, buprenorphine has a higher affinity for the receptor than a full agonist. Okay, and that'll come into play when you understand how to do an induction. Okay, I'm gonna have to stop soon. Okay, however, when it's given parentally or injected, let's do injected. If it's given IV or injected, it has a very low bioavailability. Why is that important? So if I'm giving, someone's in addiction, mom makes them go into the clinic, they don't really want to go, and they decide to take their Suboxone and, I don't know, melt it, crush it, whatever, and try to inject it, well, guess what's going to happen? Well, it's not going to give them a high because it has a very poor availability injected. However, naloxone is the opposite. Naloxone. Okay. This was opposite. Naloxone has a very low bioavailability orally. So when you take it orally, it doesn't precipitate withdrawal like you would expect it to because it has a low bioavailability. But if you inject that bad boy, it has a very high bioavailability. And if you are abusing opiates and you inject this, you're immediately going to go into withdrawal. And people on the street know that, so they don't abuse it. Now, drug dealers still sell it because there are people that don't want to be high. They don't want to, do all the other stuff associated with opiates, so they'll buy Suboxone from the drug dealer instead of going to the doctor. So it does have street value, but that kind of plays into the hands of the people who's trying to treat this epidemic. Because I'd rather people on the street be on Suboxone than on heroin and fentanyl. You see what I'm saying? So, kind of a win-win for the doctors and the drug dealers, okay? So I'm going to pause there. In my mind, Suboxone is the closest thing we have to a magic bullet for opiate addiction because I can protect you from overdose and I can discourage you from injecting and abusing it, and you can live as normal life as possible on the medication and feel totally normal. Unfortunately, you still have to take the Suboxone, okay? Now, over time, you may be able to taper it off, but oftentimes it's very difficult to taper for a lot of patients because you lower the doses a little bit, they'll start noticing withdrawal symptoms, and they don't want to tolerate it. But the good thing is, it's not life-threatening. So with education and with counseling, you can get people off of Suboxone over time. But according to my friend, Dr. Dudley, Stephen Dudley, he's an addictionologist in Atlanta, and he always recommended just to leave them on it because the data supports that people, when they come off of them, are likely to relapse and go back to what they were doing, and more likely to go on an overdose. So for most of these patients, keep on Suboxone indefinitely. And that's what I've done in my clinic, as long as it's minimal to the patient, and that's what the patient wants to do. All right, that's all we got for today. Hope that made this a little bit more clear of a topic for you. All right. Very good.